Hi, I'm Ingledew. So I'm one of the Canadians here. There's just a few of us here today. I'm going to change a little bit. This is not so much about residency education or simulation and other things, but it has to do about, I think this is really the story of developing educational scholarship and the mistakes I've made along the way and some lessons that I've learned. And so I was kind of coincidentally doing my master's along the way, and unfortunately, the things I know now 10 years out might have enabled better what I did 10 years ago. But anyways, that's kind of the thing. The other disclosure after his dad said there's 60 slides here. I'm not a big animator, so I actually insert the same slide multiple times with like little things flying in on the next slide, so he panicked, but don't, okay? I have no conflict of interest. I actually make no money off Learnoncology. I actually self-finance it myself. So anyways, there's absolutely no disclosures for that. I'm just going broke slowly. Okay, so this is the outline of what we'll talk about. So we all know that, and I think we've addressed this a number of times today, that no matter what specialty our medical students go into, at the end of it, when they're practicing physicians, they're likely to see a patient with cancer. And I tell them that when I'm teaching them. No matter what you do, if you see more than 2 patients in your practice, you're going to see one with cancer. So if you don't know anything about cancer, we're in trouble. But the literature absolutely supports that there still is a lack of proper training for our medical undergraduate students. And I think we've all identified today that some of that is in the core training that they get during their clerkship, some of that's in the education that they get didactically, but there's a large number of students that still continue to come out and have no training or no even appreciation for basic oncology concepts, never even mind radiation oncology. Having said that, there is a body of evidence to say that intervention during medical school can actually change the way that physicians interact with cancer patients when they come out, as well as their attitudes towards them. So I guess the question is for all of us, if we all know this is a problem in our medical schools, not just in Canada, but in the United States and in Europe and so forth, what do we do to address this? And so I have to admit, at UBC in 2008, an opportunity presented itself. We had a massive curriculum renewal that came out of many of the sort of LCME things, the ACGME stuff. There was a large paper that was written in Canada about changing in medical curriculums. And out of that, we realized that we were really a stale curriculum that needed to update. And so there became an opportunity to feed in some new oncology curriculum. And it allowed me the opportunity to pilot some new objectives and some new opportunities. And so at that point in time, I said to myself, how could we start to fill, or how can we start to address this gap? And one of the things that came up immediately was that there was ways to do static curriculum within the classroom, but looking at something 4 years longitudinal that people could have on-access demand to, as well as take into their residencies, seemed like a novel way that we could integrate not only the learning that they were doing in the undergraduate setting, but into the postgraduate setting too. Technology works fine sometimes, but not always. Okay. So at the same time, too, I started my master's at UIC, and coincidentally, I was able to do a curriculum project. And so this is the upside of developing something that somebody actually very early on directed me to a very good curriculum development program. So this is the maybe one moderate success I had. So I used a curriculum development framework from Kern, and we've probably known this from before, where we basically had already identified the problem. Then we proceeded to a general needs assessment, very similar to what Dan had talked about in his scholarship slides. And certainly the literature at that point absolutely supported a need for this. Then we went on to do a targeted needs assessment, and this was basically our learners at our site. You know, really surprisingly, 40% of our graduating medical students that were surveyed that year had not interacted, or they did not recall interacting with a cancer patient during their clerkship, which is crazy because I know that once again they treated more than 3 patients, so there was a real disconnect. And they also felt that their knowledge was really poor compared to other specialties at graduation. So then we went to start to do goals and objectives and educational strategies. And I would say that the goals were, as I said, really to start to develop learning materials to support medical students in their knowledge, attitudes, and skills, providing compassionate care to oncology patients. And an interdisciplinary team assisted in the development of curriculum and objectives. But I'm going to stop with it for a sec because coincidentally, you'll see back in 2014, then actually a national group of people came together and started to develop national objectives in oncology training. And so actually these goals and objectives that we initially did in 2008 had to be revised several years later, in a good way, with a bunch more people actually thinking about it. In terms of the delivery, when we actually asked our medical students, if you saw back at the targeted point, what they thought was useful, they all identified that some sort of online learning module would be the most useful for them. where they would have access to something for all 4 years, rather than just, for instance, doing a directed elective where they only got 2 weeks exposure in a very limited fashion. And so within that, they also had identified a variety of approaches that they currently liked or were currently working for them, and so that's what we decided to start to implement. And we went with a model where actually things were written by medical students for medical students, but then reviewed by an interdisciplinary team. And so this is the result of many years of work, and it's called Learnoncology.ca. And I'll just give you the timeline. I said to you I would sort of tell you kind of how it went. So this is actually, it took 10 years to kind of get to this point, with subsequent editions of modules each year. And in 2014, as I said, we took a pause. It was a complete slight revision as we developed national objectives for oncology training, and we actually went through and revised everything and made sure that it was consistent with the current consensus. We also added an app in 2014, and in 2015 to 2018, we started to add YouTube videos too. And you can see that with each summer, as we actually had new students coming in, we always had them going back and revising the content, because the content, as with any curriculum, can become very static very quickly. And as I said, in 2014, this was the intersection with the Canadian Oncology Goals and Objectives group. And if anybody's interested in learning more about the consensus process that went through with that, you can look at it at the CMAJ Open. But as I said, it led to a substantial revision. So that's like the things that I wish I knew ahead of time, was involving a national group before I had to re-involve the national group 6 years later. But anyways, so there's a learning lesson for you. This is what, I'm just going to take briefly through what it looks like. We have online learning modules in a variety of areas. We actually have about 28 learning modules now. You can just see a brief sampling of them here. Learning modules have objectives. One of our current objectives is actually start to write the objectives and define them for what should be like a first or second year learner, to up to a third year, to a resident, or somebody in continuing medical education. They have a variety of learning techniques with them. So there's text-based, there's pictures, etc. There's virtual patients. Each module has a virtual patient linked to it. Meant so that the students can actually read the module, do the virtual patient, go back and forth, and they actually refer to each other. And here's an example. We've all seen virtual patients before. This one's on melanoma. But it has free text, it has multiple choice questions, and it even prompts them going back to the objectives that are in the module at the end of each virtual patient. We have an app that was developed. The app is sort of more like a quiz type app. It actually links once again to each of the modules, but asks students into like almost a flashcard sort of thing, like 10 top things about whatever, breast cancer, etc. And then one of the things I like the most is our new whiteboard education videos. We have them almost for every module now. And once again, for the feedback that we've had from our students, probably for most of the on-demand stuff, they've used these the most. And we're using these now in our curriculum now in the flipped classroom for our first and our second year lectures, and they're being given these in all the settings. So for instance, when they're doing lung and pulmonary setting, they're actually being asked to do that too. So as I said, this was a sort of development process, and really, I mean, the end thing is really the evaluation and feedback. That's the hardest for any sort of intervention. We rolled it out in 2011, as we said, and really, I think we were really at the bottom of Kirkpatrick's, hierarchy. Really, satisfaction and participation has been easy to show, but the fact that learning is taking place, or it's actually changing attitudes, is harder. And I think this is a harder thing, and that's another lesson, and that's ongoing for us. We are doing pre- and post-test surveys now as we roll them out in the clerkship, and as we roll them out in our first and second year lectures, and we're starting to notice a difference, but that's just local data. And so we have to extrapolate that and see actually if that goes elsewhere too. And it's certainly the feedback we've received so far is that it's favorable. Some of those things students have said, this website's given me a go-to resource that I haven't had before. I like the virtual patients because I can make mistakes. So, yeah. And certainly it's led to our feedback, which has actually led to making more YouTube videos, led to making onco notes, etc. Some of the interesting things that we've done recently is we actually are using Jasper iReports to analyze some of the mistakes that students are making in the virtual patients. I see it blinking. Okay. That's good, I like it, yeah. And so that's the summary of the product. And I think in the end, we're continuing to make this congruent with national objectives, continuing to enhance it, and continuing with the dissemination piece and the evaluation piece. And I think the real lessons and the real reflections and realities come for me to say that, honestly, I think had I known what I know now, I probably would have done things a lot differently. Somewhere along the line, I found this thing from Cook on developing web resources and online materials, and I was thinking about the resident ahead of me. And for instance, there's actually published 10-step sort of things on how to do these better than I did initially, and it actually incorporates Kern's curriculum management, but all the other things. And I think actually knowing these things would have helped a lot. These things are labor intensive, and the money for them, self-funded, is not necessarily always sustainable. So I think there are real realities. And I guess the real question is, how do we disseminate these resources? How do we expand them, and how do we continue developing them? And that's about it. And I welcome anybody who wants to collaborate on Learnoncology. It's not a sole project. We're starting to reach out elsewhere. So if you've got wonderful ideas or money, let me know.